Good evening, everybody. This is a face-to-face and a webinar at the same time. My name is Jane Olver, and I am the Medical Director and owner of Clinical London. There are people sitting here at the Clinical London Academy, and there are people listening out on the webinar. We are all very keen to hear Evgenia Anikina talk about OCT. It's going to be a form of a quiz, so you're going to have your mobile phones, those of you who are here, to do the Slido and vote on the answers. And please make sure your phones, for those of you who are in the room, are on silent. Evgenia Anikina will tell you a little bit about herself, where she trained, where she works now. I will just say it is an absolute honour to have her at Clinical London. She's an amazing ophthalmologist. She's both medical retina and surgical retina, and nothing is impossible. You show her a difficult macula or a difficult retina, and she just smiles and says, yeah, I can do that. Yes, we can sort that. So
much like you with eyelids, Jane.
A long way away, the eyelids, yes. Big welcome, Jen.
So thanks very much, Jane, for the warm introduction. So just wanted to talk to you all about OCTs today. There is a little quiz. The quiz is scattered liberally throughout the presentation, so don't feel overly on the spot. And it's a very informal thing, but it's just a little bit of fun to make sure everyone's awake. And hopefully the online participants can also join in. So I call this the overly confusing tomography, which I frequently hear it is. And this is probably the most popular topic I get for requests for talks, because everyone's got the machines and no one quite knows what to do with them, us included. So first of all, a little bit about me. So I'm a VR consultant at Royal Berkshire in Reading and Windsor. I've been there for just over 5 years. I'm also at Clinical London in Windsor and Reading privately. Trained in North London, did a few fellowships at Moorfields, VR, MR, some research, doing some research work in Royal Berkshire at the moment, some clinical trials, so that's quite an exciting recent venture. Got quite a big educational hat on as well with the Royal College, and also on a couple of international committees for sporting events, which keeps me interested. So what are we going to talk today about? A little bit about OCTs in general, retinal anatomy, a reminder, and then some common conditions people come across looking at on OCTs, macular edema, macular degeneration, CSR, and also some personal sort of pet loves of mine, which is retinal detachment and schisis and differentiating between them. And of course, my favorite vitreoretinal interface, so that's my world, looking at membranes, holes, and various other exciting things. A little bit about the future, and then we've got our quiz. There's a couple of quiz questions scattered through the talk as well. This is a talk I've given before. I have modified it slightly, and there's some extra questions, some different pictures, and some slightly changed sort of points throughout. Do feel free to sort of people in the room to ask questions, and hopefully we've got a Q&A online, have we, to be directed to me. Lovely. Through the talk, I'll have these red, yellow, and green flags, and that's just a little visual representation for kind of the urgency of the conditions we're talking about, the referral criteria. So I'm really thinking of something you see on OCT. Are you going to refer it urgently, which is under 2 weeks? More kind of semi-urgently, I call it, which is 2 months, sort of, you're going to be slightly worried about them. Or green flag, are you going to refer it routinely, or maybe not at all? Are you going to just monitor these patients? So looking at OCT and normal anatomy of the retina, I'm a little bit of a science geek. I quite like my physics. I just find it interesting. So a very short run through of the history of OCT. So essentially, an OCT scanner is like an ultrasound, but it uses light instead of sound. It bounces the light waves off interfaces, and it relies on the fact that tissue interfaces reflect light, and it's proportional to the density of the tissue, and that's why you get to see all the different layers. So the evolution of the OCT, it started in the telecommunications industry, and it really got going through the late 90s and the 2000s, which is when the hospital started getting the early machines. The first ones were quite slow and cumbersome, quite low resolution, and progressively got better as time got on. So we've got these terms, the time domain, spectral domain, and swept source OCT. They sort of do what they say on the tin. So time domain, the setup of the machine is such that there's a reference mirror inside, and it moves up and down, and it measures the signal delivered, the reflected versus the refracted signal off the mirror. And it sort of calculates the depths of tissues based on that relative difference of time span for the signal to travel. That's the kind of older style of OCT. Those are the first machines that came out. And now we've got the spectral domain, which is where you break light down into the constituent wavelengths, and then the differential reflection of each type of wavelength gives you your interface pictures. And this also facilitates slightly deeper imaging. And then we've got the swept source. This is kind of the sort of the exciting, the sort of the sexy OCTs that are modern. It uses a very narrow band of wavelengths, and it sweeps it across the interface. And then this is very fast, and it allows quite deep imaging. So we're looking at choroid, we're looking at deeper structures using this modality. And then there are all the other things. There's the angio-OCT, looking at the blood vessel networks. There's the optic disc imaging and the various protocols developed for that, anterior segment OCT, etc., etc. Now, you can OCT anything. We've been OCTing a scleromalacia patient with very thinned out sclera to look at the progression of the thinning. You know, anything you can sort of get in that field of view of the slit lamp, you can image. So here's a little retinal picture, and I think this is really important from the point of view of an OCT talk, because we have to keep all these layers in mind. You know, all these, you would have seen them multiple times, but it's a reminder that the light passes through all the layers to get to your photoreceptors and your RPE. And this is an OCT picture of exactly the same thing, showing all those beautiful layers very nicely. And in particular, we're always concerned in OCT with, the point is not showing up, but with your photoreceptor layer, the ellipsoid zone, as we call it, underneath the retina there. So, an OCT scan is essentially an optical biopsy of the retinal layers, and it shows you very nicely, and you can relate it to the type of pathology that's happening. So, into our interesting conditions, we've got our macular edema. Well, when do you get swelling in the central retina? You get it in diabetes, clearly, diabetic macular edema. You get it in vein occlusions. You get cystoid macular edema after surgery, particular cataract. You get inflammatory conditions causing it. And then there's a whole host of other sort of rare, weird, and wonderful things, including sort of tractional edema, where you get some pull in the retina causing cystic spaces, choroidal neovascular membranes, etc. Here's a lovely one. I'm sure you've all seen a patient looking not dissimilar to that. No prizes for what that is, central retinal vein occlusion. We've got quite dramatic macular edema happening here. So what do we want to do if we get a patient like this? Well, a patient like this can actually present with relatively normal vision. Until you look at their fundus, you may not know what's happening. If they've developed a macular edema as a result of their CRVO, then it's a different matter. So here's our first quiz. So you can go to slido.com and put in that number, or you can scan the QR. And I'm just going to give everybody a couple of minutes to vote. And then we'll have a look at the results. So people online can vote as well. Jane, I hope you're voting too. This is just making sure everyone's keeping awake and engaging. So, which of the following factors are not associated with an increased chance of developing diabetic macular edema? And we've got a long time being diabetic, we've got poor blood sugar control, High blood pressure, high cholesterol, or history of cataract surgery? This is a little warm-up question. So I'm just going to show the results. Well done. The majority is correct. It is indeed high cholesterol. It's actually not, it absolutely is a vascular risk factor, but it has not been shown to be associated with specifically developed diabetic macular edema, whereas blood pressure, obviously cataract surgery have been. Very good. Moving on. Diabetic macular edema. So the important factors, length of being diagnosed diabetic and the control. So those are the bigger ones. But also blood pressure plays a role in all diabetic disease development. And there's this term clinically significant, which actually we don't use so much anymore because this goes back to the time when we didn't have OCT, when we could look on the slit lamp and say, well, this is clinically significant, and therefore we should treat it. But it's this whole retinal thickening within foveal center and the distance from the disc of the retinal thickening. We don't use it so much anymore. You'll still see the term. Just the pictorial representation of what the terms used to refer to. So here are some macular edemas, and here are some exudates. So the top one, the exudates are quite far from the fovea. They're not affecting the center, they're far away, and so that would have been termed non-clinically significant, and the bottom would be termed clinically significant. So I've put my green flags on. If you do scan patients like this, you know they're diabetic, the top one, well, actually, we don't really want to see them because we're not going to be doing anything with them. They can be fine being monitored under the DRSS, being monitored by yourselves. These ones we probably do want to see. Now, the retinal thickness here is very small. We're not going to be injecting them, but it is something we're going to be keeping a closer eye on because we know that they are getting worse and that they may develop further problems. Diffuse macular edema, so you can get very sort of dramatic diabetic edema, and these are the ones that are going in for the injections of anti-VEGF. You get fluid in the retina, fluid under the retina, fluid everywhere. And these we do want to see, but again, they're not super urgent, they're not the red, because actually visual functional loss happens relatively slowly in these patients. If they have this edema for many months, then they are expected to develop a loss of retinal function, but it's not going to be instant. And then I always like to remind ourselves, I've put a reminder of the retinal layers here at the bottom, because I said it's very important looking at the outer retina, looking at the ellipsoid zone. And if you look at that scan below, you can't see the ellipsoid zone, you can't see any photoreceptors. So here is a lovely photoreceptor line, and then it stops, and where has it gone? It's missing. So actually, in this scan, even though the profile of it looks reasonable, it's got a foveal pit and it's got some retina there, this person will probably be seeing count fingers or thereabouts because they've lost completely their photoreceptor layer. And unless you're looking at that specific line, that's something you don't spot and you don't necessarily account for. So you've got atrophy of all the layers in the retinal features. It just looks kind of vague, washed out, gray. And we do want to see this, but there's very little we can do. If they've got gross edema, we might still inject them, but actually there's very little you can do once they've lost the structures. Here's a BRVO. So similar to the central retinal vein occlusion, you can get cystoid edema. We wouldn't do anything to them unless they are getting cystoid macular edema or neovascularization, but we do want to see them to check for development of such issues. Here's our CRVO. Again, here, macular edema here, well, red, probably practically, you're going to send it in urgently, and we're going to see semi-routinely, just because of the pressures in the NHS. Obviously, if you send them to Clinica, they're going to get seen quite quickly, because we have some availability for it. But once they're getting the edema, they need their injections for CRVOs. If you just get the hemorrhages and the vision remains good, we want to see them. There's no desperate rush with that. We expect a picture like that to develop edema eventually, but actually I've had a couple of patients who presented not dissimilarly who have completely spontaneously recovered. It can happen. Now this one, branch retinal artery. What flag am I going to stick up on there? Any flag suggestions? Is it going to be red, orange, or green? Or a branch retinal artery? I'll put you out of your misery. I'm going to put 2 red flags on that. I'm going to put 2 red flags on that just because this is essentially an embolic vascular event. So this is essentially a little clot that's blocked an artery. And we're worried that the same clot from the same origin is going to go and block the artery in their brain, and they're going to drop down dead. And so the artery occlusions we really, really care about. And we do want to know about these because they need a full stroke workup. So whereas your vein occlusions, you're going to be asking the GP perhaps to check vascular risk factors and referring semi-routinely. These ones you're probably going to be sending to casualty. You're probably going to be sort of really getting excited about, or at least you should be, because it's a sort of a harbinger, potentially, of worse things to come. So this is your post-surgical CMO. You would have all seen that, no doubt. Again, this typically happens a couple of months after surgery on average. So when we were seeing our patients 2, 3, 4 weeks after surgery, everything was hunky-dory. We're discharging them, and then they come back with that via yourselves. Nowadays, a lot of NHS trusts don't follow up their cataract patients, and so all of these come to you. We're very happy to see them back, but we are going to see them back semi-routinely because, like diabetes, the vision doesn't really drop instantly. We've got a little bit of time to get their drops on board for them. So, time for quiz number 2. Keeping awake. What's the descriptive term used by us ophthalmologists when we're talking about cystoid macular edema? So lovely words there for you. Crystalloid, tubuloid, petaloid, ovaloid, or none of these, and I'm all talking rubbish. I love this one. This is people getting creative with descriptions. Right? Right, not thinking too hard about it. Right, I'll move on to the results. If anyone's waiting with bated breath. None of these. Jane, did you get it? So petaloid is correct. Petaloid is correct. So we have a dark horse. Here we are. Someone thought it looked like a daisy. I don't know. It's got to have an eye of faith for that. Maybe. But it's petaloid, like little petals of a flower. There's a little aside for you. So moving on. So these are the mimic conditions for the macular edema. So example, post-VR surgery, my field obviously. Here's a patient of mine, had an epiretinal membrane peel. Here's them at first post-op at 2 weeks. It looks very similar, but there's no membrane. If I discharge this patient, he comes to you, you go, oh my goodness, they have cystoid macular edema, back they come. They don't need to, because this takes a few months to settle, because the retina's taken a few months to scrunch up under the membrane. It takes a few months to sit back down again. So actually, I don't really care about this. Unless they've had, maybe if they've had a concurrent cataract or phacovitrectomy, maybe you're thinking a bit more about cystoid then. But I actually put those patients on more intensive steroid for that very reason, and also non-steroidals, so they're less likely to get it. So usually no need to send in if you get the history from the patient. So brief covering of the AMD. This is probably the best known to most people. So we've got your dry, we've got some drusen, we've got some pigment changes of the macula, we've got geographic arch atrophy developing, also dry AMD, and then we've got our wet AMD, we've got scarring, fibrosis, bleeding, choroidal neovascular membranes, and you can get this picture transitioning from just the few little drusen or from your geographic atrophy picture, and the bottom one can transform into the top one. Now, these ones are all dry, so you'll appreciate that one on the left are some drusen and PEDs, and here's a bit of pigment migration through the retina, but there's no fluid, there's no bleeding. They might have metamorphopsia, they might have visual reduction, but there's not really much we can do at that stage. This is something that can be seen in the community and monitored. The important thing is to tell the patient to monitor their own vision and report any changes. Here's some more dry AMD with geographic atrophy. So you've got, again, thinking about our layers, you've got loss of that outer retina. Can you see how this is the photoreceptor layer? It disappears. All the outer retinal layers are completely gone. That's your geographic atrophy. But are there new horizons for this? So you may have heard about the GA treatments that are coming out. There are pharmacological treatments that are injectable, like the anti-VEGF, which rely on the complement pathway, which address the progression rates of geographic atrophy. Do they work? Trials say they have some effect. The problem with them is that they cause quite significant transformation to actual wet AMD, which is having a lot of surgeons be very cautious about them. But they are on the market, patients will ask about them, and perhaps if we can control for the rate of transformation, we can use them more in the future. They're not widely used at the moment for that reason. This is your wet. You've got fluid. Fluid can be under the retina, fluid can be in the retina, there can be hemorrhage, there can be massive submacular hemorrhages, in which case I also get involved as a VR surgeon. Or they can be small hemorrhages, in which case we're all going to be injecting them with our favorite anti-VEGF drugs. And these do need to come urgently, as soon as possible, really. In the NHS, there's a 2-week pathway into clinic, and they can walk in and probably have you sorted in the same day. And your wet can turn into this fibrotic scar, at which point it's too late to do anything. This patient probably had a submacular hemorrhage, looking at them, which, you know, didn't displace, and we've got this visual loss resulting. So this one, unfortunately, nothing to do, you know, referral not recommended, unless the patient wants to discuss low vision aids and supportive measures and things like that. So a little bit about CSR and SCISIS. So another quiz, fingers on the trigger. What is not a risk factor for developing central serous retinopathy? Being a man, being stressed, having a kid who's got some eczema, looking at the sun, or taking steroids for your asthma. Okay. People are looking suitably decided. So the results hot off the press. Having a child. I love this one. This always catches people out. Not that I take joy in this. This is something that was taught to me during training, that you have to ask the whole history of the patient. You have to probe their life. You have to be a bit of a detective. The answer is looking at the sun. Has nothing to do with CSR, causes solar retinopathy, sure, but has nothing to do with CSR. Having a child with eczema means you're putting steroid cream on your child, and then you're rubbing your eyes with your steroid hands, and you're getting CSR. And I've seen this. And if you don't ask the patient about their child with eczema, about their funny skin condition that needs a cream, about their nasal polyps they're getting steroids nasal sprays for, you don't find this out. But that is actually a risk factor for CSR. So there we are. Solar retinopathy, not a risk factor. You get this, so we're back to our outer retina. We're back to our photoreceptor layer gap, right at the fovea. This vision, I think this was my patient actually. This vision I think was about 618 or 624. So actually a significant reduction from that tiny little, very focal burn of looking. This is the same as a laser. The laser retinopathy does the same thing. The lasers particularly implicated in this are not the kind of red ones that is in this that I'm shining at you, but it's the powerful green lasers that are also free sale, but they are more energetic and they create more of an issue for us. So here's our CSR picture. So it kind of looks like any other kind of fluid under the retina, but it's kind of a bit more uniform perhaps, a bit less uniform dome shape than a PED. And in the PED, you expect the deeper layer to be bowed out as well. They get central blur, they're typically male, they're typically using steroids for something or the other. And if they're not using steroids, they're stressed, which means they're still on steroids, it's just endogenous, it's coming from their own body. Self-limiting, most of it goes away and never comes back. Some of it comes back again. Some of them becomes chronic and keeps getting worse and better. And the chronic ones we try and treat. We still don't have very good treatments. The best treatment is still PDT. PDT is still not available very widely or freely because the dye that you need to do the PDT laser is manufactured by one company in one place, and there's not enough for the world. And so it's a problem. And there are some other laser treatments for CSR, for example, the micropulse laser, which we do have at Clinica, which works in some patients, not quite as well as PDT, but at least it's more widely available and accessible. So this is a referral, but not urgent. So here's my pet subject. So this is a detachment. I'm hoping everybody will recognize the detachment. I love this OCT because you can actually see the photoreceptors getting ripped up off the RP. Look, there's bits of photoreceptor hanging down, there's bits of photoreceptor sticking up. You can see how it's been ripped up. And that's why macular detachments lose vision, because you're physically ripping the photoreceptors and then they degenerate and you never get that same vision. And that picture there, that is a myopic macular schisis. So that's a staphyloma. That's a patient who's got a lot of tangential forces across the staphyloma in the retina. And the retina starts to split if they get an epiretinal membrane. There's more tangential forces, split, split, split. Vision often quite good. A patient like that could easily have a vision of 6/9. Easily, because the dramatic picture doesn't relate to their symptoms, but you need to watch for progression. And I work very closely with optometrists in Royal Berkshire. I've got a couple of them who've got sort of my line, and they literally send me serial scans of these patients, and they say, look, everything's stable, fine. And then, oh, on this scan, it's worse, and the vision's dropped, and then they come to my clinic. So normally wouldn't see this unless the vision is dropping and the schisis is getting bigger. This, obviously, I need to see yesterday. So these pictures, I'll actually have a picture of this coming up later that's a bit better, but this is a schisis. So this is a peripheral retina schisis, one of those things you get in hypermetropes down the bottom of the retina. And I just love this picture. This is my patient again. So you get, this is an outer leaf break. So the outer part of the retina is here, and this is a gap. And then this is the inner leaf, which goes all the way up, and you can't even get it in the same picture. And this is a picture of the inner leaf a bit further out, so you can see the gaps in the inner leaf. So inner leaf breaks, outer leaf breaks. And when you get both, that's when you get a potential for schisis transformation to a detachment. But we'll come back to that. So, everyone still with me? A little bit about the vitreoretinal interface. Look at that juicy membrane, isn't that lovely? It'd be great taking that off the macula. That's causing so much distortion. How you can judge the effect of an epiretinal membrane is looking at how much vascular distortion there is. You look at blood vessels as markers, see they're all twisted up, they're all bent out of shape, they're not doing what they're supposed to do. That membrane is going to be having a visual effect. If you see a membrane and the vessels are all happy and they're all going where they want to go, they're probably going to have minimal symptoms. It's just a good surrogate marker, but that's a nice thick one which will probably benefit from an operation. So here's one again. And we're looking again at the layers, but not so much at the outer. So the outer is very important. That's what is important for vision. But actually for membrane assessment, you're looking at all the other layers. And can you see how in the center, the layers are all starting to mush together? There's not such a clear distinction between them. And that's a measure of progression of the membrane. As membranes get thicker and progress, you start losing that definition. And actually, that's a poor visual prognostic thing. Ideally, you want to catch them before then. So that membrane was a 636. Lots of distortion, lots of pull, big cyst in the center. That membrane was peeled and came down to this. So this is your tractional cyst, as I mentioned before, disappeared just because you got rid of the pull. It's essentially a sort of a vitromacular traction problem. Here's a big, long question for you. Have a read. So, which of these patients would most likely benefit from a vitrectomy and epiretinal membrane peel? I don't expect you all to be VR surgeons, but have a little think. I'll let everyone read that. Give you a couple more minutes because there's a bit more to read in this one, but I think it's an important one that I'd quite like to emphasize. So, has everyone chosen their patient they're going to operate on? Or is it everyone? Shall we make them all better? All of my registrars want to make everyone better and list them all for surgery, and I keep taking them off the list. Right, the results, we'll have a look. Very good. I'm so proud of everyone. I'm so happy. Yes, you can all be VR surgeons. Brilliant. Absolutely. I mean, this patient's got reduced vision. He's symptomatic of distortion. There's no obvious other cause. Yeah, you'll take that membrane off, they'll get better. The distortion symptoms improve best. Blurring symptoms improve less. And that's what I tell my patients. If the primary symptom is a bit of blur, they get no distortion, they don't generally notice it with both eyes open, I say, look, do you really want to have this big surgery? If they come in and say everything's twisted, I can't read, you're probably going to do well. Now, the 82-year-old with bilateral membranes and cataracts, and they're complaining of blur, take their cataracts out. Take their cataracts out, and 90% of the time they'll be happy. And if they're still problematic, you can talk about a membrane peel later, but it's a bigger op. And combining the two, it's a long time for an 82-year-old to lie on a hard table in the operating theatre. The uveitis, always be careful with them. You're going to probably upset the uveitis by doing it and not make them better, but worse. And the retinal detachments patients, well, almost all of them will have a membrane because we've fiddled with their retina and that's how it responds. But their distortion is due to the detachment, not the ERM most of the time. The key question to ask those is your distortion worse now than it was immediately after surgery? And if the answer is yes, then yes, perhaps. Most usually it's no. And then we've got the diabetics, same thing as with the uveitis. You might upset them by doing it. So some of these I will peel, but only if I've got a good sort of story of good controlled diabetes, good other eye, and one eye having these tractional cysts. So here's a vitreomacular interface. Vitreomacular adhesion on the left, the hyaloid is a little bit stuck, the vitreous is a little bit stuck, it's not doing very much. I don't care very much. But this VMT where it's starting to pull, yes, I do care about that, because 5% of these transform to full thickness macular holes, which definitely do need intervention. And a lot of these are symptomatic by themselves, so we can see them, we can talk about at least risk stratification or surgery. And here's a macular hole, so that's what VMT ends up in 5% of patients. And when they first form, they can close by themselves. I tell patients if they only noticed their visual problem yesterday and they're very clear about it, that it wasn't 100% wasn't there the week before, I say, look, we're going to just wait. We're going to see you again next month because some of them close up in the first few weeks. If they haven't done, they're not going to. I honestly haven't seen late closure. It'll happen eventually, but over a month, I will recommend surgery. And we've got good closure rates, 95% or more of whole closure. So definitely refer those. 90% success, over 90. And the success factor, so which holes are more likely to close? Small ones, shorter duration ones. Patient ethnicity actually can play a part in this, and also absence of trauma. If the holes form because they've had a bash to the eye, it's more problematic. Pet topic. Pseudoholes and lamellar holes. So pseudohole is not a hole, neither is a lamellar hole. I don't like calling them, but the terms have stuck. So a pseudohole is an epiretinal membrane that is distorting the retina in such a fashion as to create this kind of rectangular sharp profile that looks a bit like a macular hole. So that's all a pseudohole is. A pseudohole is an epiretinal membrane. A lamellar hole is a degenerative condition where you essentially get schisis, you get splitting of retinal layers, you get cavitation. This one also has an epiretinal membrane, they don't all do. And this is a degenerative condition. This one is not amenable to surgery. People do operate on them. The results are very, very modest. So I don't like operating on them because it's very difficult to sell it to the patient. Look, I'll do this big operation and you might see a couple more letters, but you may not. And it's not a very sort of satisfying thing to do. So unfortunately, these ones are visual support, glasses, a lighting, magnifiers, etc. The odd one, especially ones with a membrane, might try an operation with good counseling. So generally, don't need to see them. Now, we're almost at the end, you'll be glad to know. Where are we heading? Well, more angio-OCT. We're all using it routinely, but I think it's becoming ubiquitous, really. We're doing fewer FFAs, although I'm going to stand up here and say that nothing can replace a good fluorescein angiogram, and it's still an invaluable tool. But for routine, for example, AMD work, it's a lot of it is angio-OCT now. Better depth imaging and actually creating diagnostic criteria and descriptions of conditions referring to the choroid. That's a developing area. It's a lot of stuff going on with inflammatory disorders, looking at choroidal OCT. Higher resolution, better scans, better machines, and also automation of follow-up and AI. A lot of research going into that. We're very heavily image-based. If you can plug all these results into an AI algorithm and it spits out a pathway for the patient, you know, that's sort of facilitating high volume throughput through clinics with a lot of volume. So diabetic screening in particular, things like that, new technologies. So what do we look at? The OCT is essentially a visual biopsy of the retina. You're cutting it in half and looking at it. Remember your normal anatomy and looking at them. Don't forget your ellipsoid zone, your photoreceptor layer. Correlate the clinical picture with the OCT. We're nothing without our patient. We're nothing without the story. Patient comes in with macular edema. They've just had retinal surgery. It's probably expected. And also always remember the natural history of the condition and which way are you heading. How quickly are you going to head that way? And how quickly do you need to worry? This is a picture quiz. This is the fun bit. So, which of these is a pre-op or pre-intervention image? So some of these may have had surgery, some of them may have had other treatment, some of them may have just turned up in clinic. So what I want to know is which of these is pre-op or pre-intervention. Now I think if I go to the Slido, you can get the code and I'll go back to the pictures. Hopefully it's showing up on your Slido anyway. You can select multiples. It will allow you, it should allow you. So I need all the ones that are pre-op or pre-intervention. For those who were awake through the talk, one of them you've seen before. It's not coming up? You can scan it again? Yeah. There you go. Do you want to see the pictures again? There you go. Jane, 100% yes? Oh, no. I'll tell you what I'll do is if I leave, I'll have to leave this on. You can take a picture on or a screenshot on your phone. Or decide now, and when we go to the slide, you can click your letters. Decide now. There was no way to put pictures in the thing. Decisions made, and I can give you the code again. All right, here's the code. Multiple answers available. Okay, shall we see the results? Aha. Aha. Oh, we see it live. Look at that. Very good. Again, it's the underdog. The underdog. The correct answer is D. And I'll show you the pictures again. A, you've seen before. For those of you awake, that's my post-epiretinal membrane peel patient. So that's a pre-op image. So that's a post-op image even. B, anyone hazard a guess what B is? I mean, I wouldn't expect you to because it's a bit of my special one. There is traction. There is traction. This is the fovea somewhere here. Yeah. The interesting bit was why the traction happened in this. This is a patient who went to Spa Medica. They dropped a nucleus. They went fishing for the nucleus with the phaco probe, and they chewed up the macula. This is a macular chew, as I call it, that came to our hospital. So that is a lost eye. Nothing you can do. Put oil in. There was hemorrhage everywhere as well, but this is just a little snapshot of the fovea. Right, that bottom one, C, That is actually one of my macular hole patients. It was a very large macular hole, so I did an ILM flap. So you can see the lovely ILM flap sitting across the hole. This is first post-op. So it kind of smooths out and evens out over time, but that is a closed macular hole with an ILM flap. So it's also post-op. That's our pre-op one. That's just a very large PED. This is a patient from clinic, actually, which was a patient with a polypoidal vasculopathy. Very large polyps under there, and you got a bit of fluid, so they received anti-VEGF. Are at risk of complications such as RP rips, so we watch them carefully. Righty-ho, so we've got another picture quiz, so you're going to be noting down your numbers again before we go to the voting screen. Which of these do you want to urgently refer? Bear in mind that all of these patients have no acute symptoms and mild to moderate blurring of vision only. Which of these, and this patient has had a detachment surgery several months ago, which of these do you want to urgently refer to us? Take a note of the letters, multiple guesses available. I'll give you a couple of minutes for the letters and then we'll go to the voting screen. Who's getting an urgent referral? No acute symptoms, mild to moderate blurring. And that's true, by the way. I didn't make that up. I can. The answer is, of course, all of them. We want to see all the patients, but which ones of them need it? Yeah, you can see the pictures. There you go. These are my best OCT pictures. All the funnest stuff. I'll give you the Slido again. Do. Very good. The brave 18%. Very good. The brave 18%. It's not strictly true. Some of them you might refer routinely. Hey, cheating. But urgently, none of them. Let's have a look at the wonderful pictures. A is an optic disc pit. That patient is densely amblyopic. That is a chronic condition. They did actually have macular edema, but it was very indolent, slow developing. I did end up doing a vitrectomy on them, but they were not that symptomatic, certainly not urgent. That is not a full thickness macular hole. It is not a full thickness macular hole. If you look very closely, there is still a sliver of retinal tissue. So this is just a really unfortunate degenerative lamella defect or pseudohole. Their vision was very reasonable. It was like 618 or something. I mean, they are going to be reduced, but this is not a surgical condition. You're probably not going to make it better with surgery. If they were really keen, you would counsel them very carefully. You'd say, well, we could try, but I can't guarantee improvement. Degenerative condition. Patient had detachment surgery several months ago. Well, that's just residual fluid. You usually see that. If you scan them all, they'll all have that at some point, somewhere in the retina. The more longer standing the detachment, the more chronic, the more you get this. This takes months or years to disappear. I've seen it still persist 2 years later, gradually getting less. It's not inflammatory. It's not cystoid. It's just slowly resolving dense subretinal fluid. That one, anyone venture a guess? I mean, it looks a bit like a swollen inner retina. It looks a bit like an artery occlusion, but it's not. What it is hemorrhage under the ILM. This is a Valsalva retinopathy. They sneezed. and they bled on top of the retina, their vision is normal. And this blood, 5 days later, was gone. It just breaks through and disappears. So if this big blood clot covers the fovea, if the vision's reduced, I say, well, look, if it doesn't get better, we can operate and get rid of it. I've had one patient where I've had to operate. All the others, they've gotten better spontaneously within days or weeks. And then that bottom one, well, that's another one of our myopic foveoschisis. So you've got, that's the inner retina, that's the outer retina, there's the scitic layer, they've got a staphyloma. They're not actually symptomatic, that's very, very chronic. So this is something that could even be monitored in the community if they were stable. So there we are, there's my wonderful picture. I've got some more pictures, but no questions, you can all relax. Some more funky OCTs that I couldn't fit into the quiz. Just for your entertainment value. I've got a picture of a normal retina there for reference. So over here is an example of the deep imaging. So this is a very thick choroid. So you can see the extended depth imaging for the choroidal structures. So this is, I can't remember who this one was, but it's an inflammatory spectrum and something or other. This is the skies that I was talking about. Look, there's the outer retina and the inner retina with all the inner leaf breaks. So as long as there's inner leaf breaks, we don't care. If there's outer leaf breaks, we don't care. If there's inner and outer, that's when it can transform to a detachment because you can get fluid tracking through both. So those ones we're a bit more worried about. That is a trauma. That's a choroidal rupture. That's an impact to the eye, and they split. Unfortunately, they got the choroidal rupture right at the fovea, which frequently happens. So big vision loss, nothing to be done, unfortunately. That one is a well, there's some edema there, but this was an artery occlusion. So you got some swelling of the inner retinal layers. It's quite subtle. You kind of look at it and you think, oh, what's going on? But in the context of history, that's important to look at. That is an epiretinal membrane, just demonstrating that it can have cysts. There's some cystoid cavities there from the traction. There's a tractional edema. We often get referred them as CMO. It's not really CMO, it's tractional fluid. So we expect that to get better if you remove the membrane. And that was an interesting case that I still don't know what's going on because it was a child, it was a refugee child, and they had the same picture in both eyes, very, very strange looking retinas. They've probably got some genetic issue, but they haven't got a foveal pit, they've got this foveal elevation, and they've got all these interesting whorls on top of the retina. So they've been sent for genetic testing and for genetic clinic review. Thank you. Stay in touch and enjoy the rest of the evening. Wonderful. Please do.
The online people have not made any questions. Can I encourage them to quickly?
All questions welcome. I think everyone's stunned into silence by the quiz efforts.
May I congratulate everybody who's been here doing the quiz and those online getting many of the results correct. So thank you very much for participating. And Jen, an enormous thank you for an eye-opening, illuminating talk on OCTs. They are so beautiful to look at, and some of them are definitely quite mysterious. So thank you very, very much from all of us.
Overly confusing. Pleasure. Thank you.
We have a small gift to give you now. Very small gift. And then there's more refreshments and chatter, ask her any questions that have come to mind. I'm sure she'll be happy to show more pictures.
Always happy to show more pictures. Oh, thank you. Thank you, Jane. Thank you. Thank you very much.
Thank you. Beautiful.
Thank you all. Please do partake of more refreshments and hope to see you all again. And hope to hear from you.
The next meeting is going to be in January. Is it January the 14th? It's going to be by Michelle T on lumps and bumps around the eyes. So when to get worried about which bumps and lumps or lumps and bumps and to refer and when not to. And she'll give you a little bit of the scope of what she does in the ocular plastics eyelid world. And we'll continue having the Clinical London Academy meetings throughout the rest of the year with a small break in Easter in the summer. And you're all very welcome back. I really like face-to-face, even small numbers is fantastic. Thank you. Refreshments.